with this excellent group of collaborators, we wanted to write a paper that emphasized how important it is that patients at high risk for atherosclerotic cardiovascular disease, heart attack, and stroke, why it's important that they get maximal LDL lowering. And that is accomplished by being on a high intensity statin, or if that's not possible, a moderate intensity statin plus a drug that affects cholesterol absorption called ezetimibe. I'm Dr. Neil Stone, and it's my pleasure to present a brief capsule of an article being published in the Mayo Clinic Proceedings this fall. It's called High Intensity Statins Benefit High-Risk Patients: Why and How to Do Better. Scott Grundy and myself were the lead authors, and we were joined by other authors involved in the clinical guidelines called Roger Blumenthal, Lynn Brown, Paul Heidrich, Don Lloyd-Jones, Carl Oranger, Joseph Sassine, Sidney Smith, Lawrence Sperling, and Salim Virani. Too often, patients at high risk are undertreated with LDL-lowering therapy. Everybody is aware that patients who've had a coronary event or a stroke need to be on high-intensity statin or a combination that lowers LDL by 50%, but many may not be aware that there are 4 groups in primary prevention that benefit also from this aggressive therapy. Those are patients with severe primary LDL cholesterol greater than 190, some of whom will have familial hypercholesterolemia, a lifelong high cholesterol disorder, those with diabetes 40 to 75, and risk factors that put them at especially high risk involving duration of their diabetes and evidence of microangiopathic disease. Those in primary prevention, 40 to 75, who have a 10-year risk score greater than 20%. And finally, those in intermediate risk who had a coronary calcium score measured because a risk decision was uncertain and it was found to be 300 or greater. And what our article does is it discusses the reasons that they should be treated this way. I won't go into all the studies except to say that there is strong evidence that patients should have their LDL lowered aggressively if they're at this high-risk stage. Indeed, in those with coronary artery disease with a recent coronary event who are called very high risk, they need to not only have statin, high-intensity statin, and possibly ezetimibe, but some of them will benefit from a PCSK9 inhibitor as well. But what are some of the problems that are associated with why doctors don't do it? Well, part of it is because many clinicians are not aware that approximately 90% of patients can tolerate high-intensity statins without substantial statin associated adverse effects. And there are strategies available, like I've indicated, to drop to a moderate intensity and add a drug called ezetimibe if they can't tolerate the high-intensity statin. The idea is to get at least a 50% or more reduction in LDL. The greater the LDL lowering and the higher the risk, the greater the benefit to the patient. It's important, though, not to focus just on LDL, but to remember that smoking cessation, blood pressure control, blood glucose control, weight gain control are very important when you deal with the high-risk patients. But we're just going to talk about the cholesterol issues. It's also important to make sure that the patient doesn't have low thyroid, nephrotic syndrome with protein in the urine, one of these extreme diets, such as a ketogenic diet where they have very high saturated and trans fat intakes and high LDLs, uncontrolled diabetes, or certain medications, because all of these are secondary factors that can be controlled and perhaps make the high intensity not needed. It's important when people are on these medicines to realize that not all symptoms are caused by a statin. That's why the guidelines called symptoms on a statin, statin-associated symptoms. Careful questioning as to location, timing, and other causes of discomfort may reveal the exact nature and allow the statin therapy to continue. Some people need a challenge so you can be sure that the symptom is due to the statin, because some studies have shown that up to 40–50% of people may have symptoms on placebo as well as the statin. In other words, the symptom was not being caused by the statin. And lastly, it's important to monitor patients regularly. Now, what are some of the tips that might be used to go over some of the barriers that people have? Some people are afraid of muscle symptoms, but you can point out that the randomized controlled trials show really no difference between the treated and the control groups in many of the trials, and that a lot of the muscle symptoms may in fact not be statin induced, but if they do get them, we can always go through a de-challenge cycle. There is a slight increase in diabetes. In one study, the Jupiter study, high intensity statin was associated with an increased risk for diabetes in those with diabetes risk factors, but not in those without. And the benefit from being on a statin for those with diabetes risk factors far exceeded the risk of the blood sugar being elevated. Some people are afraid of drug interactions, but there are many tools to check drug interactions to make sure that doesn't occur. Many people are not aware that we have good data to show that getting LDL down in the secondary prevention range below 70 indeed results in fewer events. Prior guidelines didn't have that data, but now we have data to show that getting LDL lower with medication proven to benefit the patient without inordinate risk of side effects is very important. The good thing about cost is we now have low-cost generic high-intensity statins. And it's important for people to realize that if we can give people a once-a-day simple pill, very often that may be all they need to control their LDL, because many patients start the day with LDLs less than 140, so their LDL with a high-intensity statin will get to be less than 70. Lastly, we pointed out there's some wonderful patient support materials. People want to do their own research. Tell them to look at CardioSmart for the American College of Cardiology, the American Heart Association, the National Lipid Association, Preventive Cardiovascular Nurses Association, up to date, and I should add the Mayo Clinic website is a superb source of information. So this is, in summary, a paper that presents the strong evidence that people at high risk for atherosclerotic cardiovascular disease benefit from substantial LDL lowering of 50% or more. Too often such patients, as I've mentioned, are unnecessarily undertreated and the LDLs stay too high. The clinician needs to discuss the advantages of this and monitor periodically for efficacy adherence, and realize that if problems occur with getting to a high intensity, a moderate intensity, and a drug like ezetimibe can often give you the 50% lowering you'd get with a high intensity. And of course, for people with atherosclerotic cardiovascular disease who really have trouble getting to the goals for secondary prevention, strong consideration should be given to use of the new drugs, the PCSK9 inhibitors, injections that are given every 2 weeks. I hope this has been of help to clinicians out there. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.